Do you see the presentation on the screen?
Yes, yes, Lopez.
Okay. We'll begin. I'm going to, first of all, thanks for the invitation to expose the work for my team. I'm going to talk about the clinical aptitude or suspicion of malignant breast pathology in primary care physicians. This is in Mexico. I'm from the Mexican Social Security Institute. Actually, I'm on a rural hospital. We'll begin. Let's introduce a little in the work. In Mexico, there was no established diagnosis protocol for breast cancer until 1994 in the Colima Mexican Consensus. This had a great division in oncology specialists, but not in primary care. These are most probable to have an oncology pathology, to have a tumor, not only of breast, it can be also prostate, stomach, lymphoma, leukemia, and other ones. According to statistics, 45 of new breast cancer cases are in developing countries, one of them, Mexico. According to Globocan 2020, 50% of Mexican population with cancer have breast cancer. This includes men and women. In women, this is 28.2% of all cancer cases in women. Thus, we have, this is the first cancer, the first place of cancer pathology in Mexican women. We know there are risk factors for developing breast cancer. This can be biological, iatrogenic, reproductive, and from the lifestyle. Biological, we have to be female, age, familial history of breast cancer, atypical ductal hyperplasia, high mammary density, early menarche, lately menopause, and mutations in the BRCA. Iatrogenic, we can find thoracic radiotherapy. Reproductive, no pregnancy, no breastfeeding. First way of sedentaries, which is a public health problem in Mexican population. We had the first place in obesity worldwide, alcohol consumption and smoking. Thus, we started research about breast cancer in Mexico, just about the diagnosis, because in Mexico there are too many campaigns that are focused on the patients to make them conscious that if they identify a tumor is a change in the skin of their breast, they have to go to a clinical exam. But according to statistics, we will see that although these strategies exist, we are still diagnosing breast cancer in advanced clinical stages. This means that clinical stage 3 and 4. So we found that there was a time interval when the problem begins and the treatment begins. This was this was exposed by Carl Unger Saldaña in 2009. She found that the total for a breast patient to be diagnosed and start treatment was in average 7 months, going from 4 up to 40 months. The World Health Organization suggests that this time should not be longer. From here, we can see we are doing something, we are missing some things in the approach of a cancer patient, specifically breast cancer. Patient interval was 0 to 2 months. But the health system or health provider interval was found to be an average 5 months, going from 3 to 9 months. This was divided from the first medical consultation that goes up to primary care, going from 2 up to 8 months. Specifically, the pre-hospital interval going from 2 up to 12 months. This is unadmissible according to the World Health Organization recommendations. And as we can see in this figure, this is the most time in all the diagnosis and treatment interval. When the patient arrives to a cancer institution, the patient begins from the first up to the 3 months. Thus, in 2002, Marino made a study of the approximately cost of attending a breast cancer patient depending on their clinical stage. This was published in 2009, but the data is from 2002. There are no more studies about this. This is the only one we found in Mexico, specifically in the Mexican Social Security Institute, who is the main healthcare provider in Mexico. So we found that attending a clinical stage costs about $6,800 by patient by year. A clinical stage 2 goes up to 10,000. A clinical stage 3 goes up to approximately $50,000 by year, and clinical stage 4 goes up to more than $80,000 by year. Also, with a worse prognosis and a worse life quality. Here is a table from 2019 about the clinical stage where are diagnosed the breast cancer cases in Mexico. We found that the most are in advanced stage, starting from clinical stage 3A, 3B, 3C, 4, and others that were not classified. So we made the question, which is the clinical aptitude of primary care physicians on the suspicion of malignant breast pathology? Because we identified that here we had a problem, but a problem cannot be solved if we don't measure it from the beginning. So we found that clinical attitude is the ability to recognize risk factors, make a prognosis, selection and interpretation of laboratory imaging studies, the ability to make differential diagnosis, and explain risks and benefits of different therapeutics to the patients, and if possible to collaborate with other services with other colleges. The justification of this was that the current evidence shows that clinical attitude in primary care physicians is unacceptable. In Mexico, family medicine specialty does not have a specific place and time for the teaching of medical oncology. Also, oncology pathology is becoming a public health problem in Mexico. More than 50% of the patients are diagnosed in advanced stages, and to identify areas to optimize breast cancer patients' approach in primary care. The methodology, this was a cross-sectional observational study population where family medicine specialists, family medicine residents, and general practitioners from familiar medicine unit number 20. In Mexico, I don't know how does it work in other countries, but in Mexico, a person that studies it's 6 or 7 years of medicine can practice medicine when finishes the school and can make a medical specialty. Here we use non-parametric statistics and a questionnaire of 5 clinical cases with 25 questions, each one where we evaluate risk factor identification, clinical reasoning, diagnosis approach, integral management, and follow-up and prognosis for every patient. The objectives, the main was to determine the clinical attitude of primary care physicians of suspicion of breast cancer. And other objectives were to identify general data, professional data, and stratify clinical attitude level, compare clinical attitude with general and professional data. Inclusion criteria, doctors who are attached to Family Medicine Unit 20 of any gender. Exclusion, doctors who do not wish to participate, and doctors who are at holiday laboral license or complementary clinical practice. Elimination, doctors who do not answer all the questions or want to retire in any moment. The clinical attitude levels were certified in 6 levels, going from random with 0 up to 25 correct answers, very low, 25 to 49 correct answers, low, 50 to 74 correct answers, enough, 75 to 86 correct answers, 9, 87 to 105 correct answers, and high, more than 106 correct answers. In a 0 to 10 scale, we found random was 0 to 2, very low 2.1 up to 3.9, low 4 to 5.9, enough 6 to 6.9, nice 7 to 8.4, and high more than 8.5. The gender of the participants, the most were females, having up to 70% of the participants. The participant category, we found that there were 4 general practitioners, 18 first-year residents, 14 second-year residents, and 9 third-year residents. Family doctors were 39. To have a total of 84 participants. The general clinical attitude of all of them was random in 6, very low in 2 participants, low 35 participants, enough 23 participants, nice 17 participants, and high only 1 participant. In percentage, random represents 7% of all participants, very low 2.4%, low 41.7%, the predominant clinical aptitude level. in this study. Enoch, 27%, nice, 20%, and high, only 1.2%. The clinical aptitude in correct answers and score 0 to 10 was for general practitioner in score 0 to 10 because it's easier to explain. 3.9, first year resident, 5.51, second year resident, 6.24, third year resident, 6.15, family doctors, 5.6, and the total average of all of them was 5.6%, which occurs to other studies of similar characteristics done in this kind of population, but of another health problems. We found that risk identification in all cases was going from enough up to nice. The diagnosis was very low in the general practitioners and low in the other categories, going from first year resident up to family doctors. Clinical reasoning was very low in general practitioners and was low in all residents and family doctors. Clinical reasoning also was very low in general practitioners and low in the other categories. Integral management, we found it was very low in general practitioners and low in the other categories. Follow-up was very low in general practitioners and low in the other categories. And prognosis, it was random in general practitioners, low in first year residents, enough in second and third year residents, and then it drops to low in family doctors. So, because we use non-parametric statistics, we use Young-Hilterstraat test that is similar to Kruskal-Wallis, but Kruskal-Wallis differs that Kruskal-Wallis does not need that every category precedes or proceeds everyone. Explain as I done from the beginning. In Mexico, the categories go from general practitioner, then they enter to a medical residence first year, second year, third year, and finally the specialist. Young-Hilterstraat test gives us the possibility to analyze in a better way these groups when there are they have an order and every category precedes or proceeds the another. So we found that the score from 0 to 10 was significant, was statistically significant in all the categories. There was difference statistically significantly, but in the clinical aptitude, we did not found difference. And the only subject we found statistically significant difference was in the prognosis with a p-value of 0.04. We made experiment correlation to see that these differences were in a positive or negative way. So we found that the category had a minimal but positive correlation with the p-value of 0.04. The other ones did not find a significant p-value. This was above 0.05. We found that family medicine is the main specialty in any health system Mexico is not an exception. The main responsible in Mexico of the training of family medicine residents is the Mexican Social Security Institute. And the main purpose of the institute is to give integral attention to the most common health problems in Mexico, where the family doctor needs to be the specialist with the most improved clinical aptitude to approach every health problem in a familiar and biological context. We found a low and very low clinical participants, giving us the evidence that medical attention given in oncology problems in primary care is far from being optimal. This represents a problem in medical attention because family medicine residents cannot realize actions that benefit the patient, and the approach of their problems can be as large as 40 months according to the evidence. Another problem is that in our clinical training, family medicine residents are evaluated by other medical specialties, which are allowed to be in hospitalization and external consultation of any service in a oncology hospital or in a hospital with oncology service. They send us out from the external consultation. The first thing they ask us when we go from the first time is from which specialty do we come from? And if we say family medicine, they don't want us to be there. Family medicine residents need to be included in other medical specialty services as hospitalization and external consultation and receive orientation and clinical abilities from every specialty. Family medicine residents need to be admitted in medical oncology services, such as external consultation, because it can impact in a positive way the public health of our country by giving them the clinical aptitude to have cancer suspicion and make an opportune diagnosis. This can lead us to have the most diagnosis of cancer pathology in early clinical stages. And we ask medical oncology, oncologic surgery, and gynecology oncology specialists to admit family medicine residents in their external consultation service to improve their clinical aptitude with the most common cancer types in Mexican population, such as breast, lung, prostate, stomach, leukemia. It's evident that we are not going to have the same clinical experience and clinical aptitude that a medical oncologist or an oncologist surgeon has, but we can learn from them to identify patients early and give the patient a more comfortable and good prognosis. I want to make a special mention for my teachers and give my gratitude to them. Dr. Claudia Cesarinas, my main teacher and mentor, Dr. Chris Van Biel, Dr. Marcela Lopez Cabrera, Dr. Maria de Lourdes Martinez Zúñiga, and Dr. Elvira Bautista. Thanks for your attention. This is the citation for the work, and this is an email for contact. I was very pleased to participate in this.